Welcome to the presentation for Nursing 150, Module 3. This presentation will discuss care of the patients with inflammatory disorders of the lower intestinal tract. Acute inflammatory bowel disorders include appendicitis, gastroenteritis, and peritonitis. These are the most common acute inflammatory bowel problems. They can be potentially life-threatening disorders, and they can have major complications if not treated properly. Appendicitis is a common acute inflammation of the appendix. It does occur most often among young adults. It is the most common cause of right lower quadrant pain. And it's the right lower quadrant because if you reviewed your anatomy and physiology of the GI system, you know that the appendix usually extends off the proximal cecum of the colon, which is just below the ileocecal valve. And so anatomically, that structure lays in your right lower quadrant. So that's where the pain is initiated there. Inflammation occurs when particles get stuck in the appendix. There is a small opening off the intestine to the appendix, and particles get stuck in there. As particles get stuck in there, it blocks and obstructs it, leading to infection as bacteria invade the wall of the appendix. As the inflammatory response occurs due to the blockage of the appendix, the patient will complain of increased pressure and pain in that right lower quadrant. A couple of things can happen when appendicitis occurs. If it's a slow process, an abscess may develop, which can cause a lot of pain and discomfort. If it happens rapidly, if the inflammatory response happens rapidly, it could result in something called peritonitis, which we will talk about in the next few slides. But this is a life-threatening situation because then if the appendix bursts and all of this particles that have been trapped in the appendix are now in the peritoneal cavity, all this bacteria is released into the peritoneal cavity. It can make the patient develop a peritonitis, which can quickly lead to sepsis in a life-threatening situation. The older adult is more commonly associated with a perforation. The diagnosis of appendicitis is difficult to establish in older adults because symptoms and pain and tenderness may not be as pronounced in an older adult. So basically, it might not be found and treated as quickly as if a younger adult has it. So the older adult is more at risk for a perforated appendix, which could lead to a peritonitis, which is a life-threatening situation. Gangrene and sepsis can occur within 24 to 36 hours and are some of the most common indications for emergency surgery. Perforation may develop within 24 hours, but the risk rises rapidly after 48 hours. Perforation of the appendix also results in peritonitis with a temperature of greater than 101 and a rise in the pulse rate. So if we admit a patient with an appendicitis, a nurse's job is to continuously monitor that patient for any change in their condition that might indicate that the appendix has burst. And if that happens, we have to call the provider right away because the patient is at risk for peritonitis, which is a life-threatening situation. Here is a picture of where that appendix sits in that right lower quadrant. The assessment of McBurney's point is an assessment indicative of appendicitis. McBurney's point is located midway between the anterior iliac crest and the umbilicus in the right lower quadrant. This is a classic area for localized tenderness during the later stages of appendicitis. Appendicitis pain is typically it's abdominal pain that increases with cough or movement and is relieved by bending the right hip or knees. When a patient is doubled over in pain and kind of in the fetal position, that can be indicative that the appendix has burst and that the patient might be experiencing a peritonitis. So identifying a patient with appendicitis, you need to perform a complete pain assessment. Initially, pain can be present anywhere in the abdomen or flank area. As the inflammation and infection progresses, the pain becomes more severe and steady and shifts to the right lower quadrant and that McBurney's point. There is a pain. The patient may report pain after release of pressure, which is commonly referred to as rebound tenderness. So essentially, the provider will press on McBurney's point area, and when they release, if the patient's pain is increased on release, that is a rebound tenderness, which it goes along with the diagnosis of appendicitis. Interventions. All patients with suspected or confirmed appendicitis are hospitalized and must have surgery to remove the inflamed appendix. Preoperatively, we need to keep the patient NPO to prepare for the possibility of surgery. So after we hospitalize them and we're prepping them for surgery, we need to know that IV fluids are started to maintain fluid and electrolyte balance. Keeping the patient in a semi-Fowler's position, just to make sure that gravity can keep the abdominal drainage lower in the event that it does. The appendix does burst. Once the diagnosis of appendicitis is confirmed and surgery is scheduled, we might give opioid analgesics, and we will also begin to administer antibiotics just as a preventive thing in the event that the patient does have a burst appendix. The patient with suspected or confirmed appendicitis should not receive laxatives or enemas, which can cause perforation of the appendix. Do not apply heat to the abdomen because this may increase circulation to the appendix and result in increased inflammation and perforation. Surgical intervention is an appendectomy. It means the removal of the inflamed appendix. Typically, they are uncomplicated procedures done with laparoscopy, which means just a small incision. Patients will need help postoperatively with monitoring the incision site for infection and pain control. They will also need assistance with making sure that they can get up and get moving. Antibiotics and pain medication will be interventions. Teach patients to refrain from lifting anything for at least 6 weeks after the surgical procedure. Patients who have laparoscopic surgery can resume activities within a week or two, but it just depends on the patient and the procedure, and so they will have some restricted activity, and we'll just have to make sure we know what those are per the provider and then educate the patient on those. Gastroenteritis, again, is a common problem that most of us maybe at one time in our life have had. It's basically an irritation, and this is talking more about the lower bowel, so the small bowel and the large bowel, where it causes a diarrhea, vomiting, and it's an inflammation of the mucous membranes of the stomach and the intestinal tract. So we kind of talked about gastritis in the last presentation being more of an irritation to the stomach, associated with maybe food poisoning. This is kind of a similar situation, but we're talking more about inflammation of the stomach and the lower intestinal tract as well. Viral gastroenteritis is the most common cause. And this is one of those nasty little GI bugs that you'll hear patients or your friends or family talk about. They got that GI bug. That's what they're referring to as that viral gastroenteritis. The good news is it's typically very self-limiting. It's a virus that we kind of have to let run its course. People we have to keep an eye on are the people who are immunocompromised, older adults, small children, because they can quickly become dehydrated by a gastroenteritis. That's the biggest problem that it causes is, you have this profound diarrhea and vomiting and you can't keep anything down. So people who are already ill or older or already immunosuppressed, it's gonna hit them a little bit harder, and so they perhaps might have to be hospitalized to get some IV fluids when they have gastroenteritis. And the normal healthy people, they can typically kind of manage through it if they get some Gatorade, some fluids, if they can try to keep some stuff down. But that's something we're always on the lookout for with a patient with gastroenteritis. Nursing care of these patients is, again, monitoring for signs and symptoms of dehydration and making sure that that gets addressed, maybe with IV fluids if they can't keep anything down. But also doing that, that very focused abdominal assessment, checking for distension, checking bowel sounds, making sure they have good urine output. And that would help us to determine the dehydration status. So eyes and nose, things like that are very important. So we need to encourage fluid replacement. One of the important things is that we would not want to give them like an Imodium. Imodium is a medication that decreases intestinal motility. Where some people are instinctively want to take something like that, like an Imodium for diarrhea. But if they have a viral gastroenteritis, we don't want to do that because use of these drugs can prevent the infecting organism from being eliminated from the body. So if we give them something to suppress their intestinal motility, they can't get this virus out of their body. So don't want to do something like that, even though it's kind of intuitive to want to take a medication like that, but they should not. Okay, moving on in the next few slides to a more chronic inflammatory bowel disease, we're going to talk about ulcerative colitis and Crohn's disease, which are very similar diseases. They cause kind of similar signs and symptoms, and they're treated somewhat the same, but it's important to kind of know the things that make them a little bit different from each other. Ulcerative colitis is a widespread inflammation of the rectum and the rectosigmoid colon. It can extend to the entire colon. It is thought to be an autoimmune disorder. It's important to be familiar with your anatomy and physiology of your digestive system. I'm going to kind of try to draw a large intestine here, a large colon here. So this is ascending, transverse, and descending colon. And so before this we have the small intestine. When you hear the word colitis, we are specifically mostly talking about the colon, which is the large colon. And as you can see here, we're talking around the rectum and the rectosigmoid colon, which is this area here is where you're going to see ulcerative colitis the most. It can extend through this whole colon, but for the most part, it's down low here. That's what kind of sets it apart from Crohn's disease. And you'll understand that a little bit more as we walk through the difference between ulcerative colitis and Crohn's disease. Both are thought to be autoimmune, so that is a similar thing. So both autoimmune, but they affect different areas of the colon. And I have some good slides here that kind of help show that the inflammation and the problems that it causes within the lower GI tract are a little bit different. Diagnosis of ulcerative colitis will be some labs that would show maybe an increased white count from the inflammation. C-reactive protein, ESR, are going to be elevated because they are consistent with an inflammatory disease. Other things, we'll do some GI diagnostic tools. Colonoscopy is usually pretty helpful in the diagnosis. Sometimes the bowel prep that they have to do the day before, though, can be a little bit too much for a patient who has an inflammatory bowel disease. But it does allow us to have a visual look at colonoscopy as a scope that we would take through the rectum and be able to go in and look at that colon. But like I said, the prep for that is taking the whole day before they have to drink a laxative to clear out the bowel, and sometimes that's a little bit difficult for a patient with an inflammatory bowel disease. So basically what happens here is this inflammation within the colon causes a lot of loose bowels, a lot of diarrhea, and so what that does is prevents the patient from being able to absorb what they need from the GI tract, and they end up with some fluid and electrolyte imbalances. The inflammation area, the inflammatory area, is edematous and redden. And more severe inflammation in the lining can bleed, and small erosions or ulcers occur. They can develop abscesses. Continued edema and mucosal thickening can lead to a narrowed colon and possibly a bowel obstruction. So it can actually, the edema can actually obstruct the flow. So lots of different problems that can develop, complications that can develop from ulcerative colitis. So essentially what we have to do is try to decrease the inflammatory response. So we can do a few different medications to try to decrease that inflammatory response. Non-surgical intervention includes drug and nutrition therapy. In this incidence, we can use anti-diarrheal medications such as Lomotil or Imodium. We can use glucocorticoids such as prednisone. These corticosteroid therapies will decrease the inflammation from the ulcerative colitis, allowing better flow through the colon. Diet therapy is typically having the patient avoid anything that they can identify as an irritant that will cause the colitis to flare up. Typically caffeine and alcohol increase diarrhea and cramping. For some patients, raw vegetables and other high fiber foods can cause the GI symptoms. Sometimes it's a lactose containing food, so it's a matter of the patient being able to identify foods that they eat that increase the incidence of the diarrhea and the cramping. And then they should be taught to avoid those foods that exacerbate the disease. Ulcerative colitis is a disease that is a process of exacerbations and remissions. So it gets better, gets worse, gets better, gets worse. Typically things like poor diet, stress, fatigue will tend to cause a flare-up. So the patient needs to get adequate rest and really just kind of take care of themselves. The better health that they have, the less likely they're going to have an exacerbation. Okay, moving on to talk a little bit about Crohn's disease. It is another chronic inflammatory disease of the small intestine. It's most often the small intestine, but it can affect the colon or both. It can affect the GI tract from the mouth to the anus, but most commonly affects around the terminal ileum of the small intestine. It's slowly progressive and unpredictable disease with involvement of multiple regions of the intestine. Like ulcerative colitis, it can have remissions and exacerbations. It is again thought to be an autoimmune disease process that causes this inflammatory response within the GI tract. Some of the major signs and symptoms that support the diagnosis of Crohn's disease as opposed to an ulcerative colitis is the fact that it is found in a more spread area in the GI tract. Strictures and deep ulcerations with a cobblestone appearance are more indicative of Crohn's disease rather than just that inflammation. They actually have these strictures and deeper ulcerations. The patient are more at risk for developing fistulas, which are abnormal openings between two organs or structures. The result is severe diarrhea and malabsorption of vital nutrients. They are commonly anemic because of their malabsorption issues. Complications associated with Crohn's disease are similar to those of ulcerative colitis. This slide was put in here as an attempt to help you to see the difference between ulcerative colitis and Crohn's disease. Again, as I said, ulcerative colitis is typically the lower part of the large bowel. Crohn's disease is more known to have something called skip lesions, where they're kind of more throughout, spread throughout the GI tract. And again, like I said, there are deeper fissures here that may lead to fistulas, which can be something that has to be repaired surgically. Here's another visual to kind of see the difference between what the two diseases look like. Again, here are those deeper fissures from Crohn's disease. And then this is, so the large intestine with ulcerative colitis just essentially appears just like a red inflamed area rather than these deeper fissures. And what happens with the fistula is when another organ is here against the, so if this is another organ sitting here, these fissures might actually get so deep that they break through, and so then there's a connection between, a lot of times this happens in women and men sometimes when they're with the bladder, so they'll have a fistula between their intestine and their bladder, which can cause some very serious life-threatening situations, and so they will need to have surgery to repair this fistula. So important things to think about with these chronic bowel inflammation diseases. Major problems. Patients are typically have malabsorption, which leads to some fluid and electrolyte imbalances. Pain due to the inflammation. Just a social aspect of having a lot of chronic diarrhea. They also have to, manage their diet so that they have less exacerbations. Medications, a lot of times they're on a steroid medication, which is an anti-inflammatory medication that puts them at risk for infection. So they will need to avoid crowds, avoid people who are sick, because it does suppress their immune system. There's also medications out there called immunomodulators, and they are drugs that alter a person's immune response. Alone, they are not often they usually aren't used alone, but in combination with steroids. These are drugs on the market. They're difficult to say. It's infliximab or Remicade or adalimumab. So they end with that, MAB. Those are immunomodulators. I know them brand names as Humira and Remicade, but they're infliximab. They are infusions typically that the patient will have to go in to an outpatient infusion center and have, usually it's like, it depends on the patient's numbers of exacerbations, but it's typically like every other month. Sometimes it's once a month that they go in and they get the infusion. But essentially what it does is it alters their immune response, so it decreases that autoimmune response that they're having that's causing their signs and symptoms. Again, these medications alter their immune response, so they do cause immunosuppression and need to be used with caution. Teach the patient to report any signs of infection, including cold, and to avoid large crowds and people who are sick. These patients often have to be treated with surgically, like I said, for fistulas for sure. If there is a severely inflamed area of their bowel, sometimes parts of their bowel might have to be removed. In severe cases, they might have to have an ostomy placed, which means the bowel has to be brought out through the abdominal wall. And an ostomy develops so that, if a large part of their bowel has to be removed, that may be the only way for them to be able to eliminate from the GI tract. So it's important that you review the care of a patient with an ostomy, especially post-operatively, in the first 24 hours. And we will discuss this a little bit further in my next presentation, but it's important to go ahead and start to review the care of a patient with a colostomy, how to help them manage it, how to teach them to manage it, and how to assess it. This concludes the presentation for Module 3. of the lower GI tract, the inflammatory disease process of the lower GI tract. The rest of the slides are a few questions just to assess your learning and assess your understanding. I encourage you to attempt to answer them and find the answers that have been posted in the presentation without voice. I look forward to discussing these topics with you in class.